Rachel is a very interesting case. We had the pleasure of having her with us for examination purposes and to give you a nice picture of an individual who's had an ACL injury. It was involved with a fall. And in our presentation, what's very interesting is to note that her hyperextension is present. Almost everyone who tears their anterior cruciate, unless it is a direct blow related to an athletic event or a motor vehicle accident, et cetera, almost always, 80 to 90% of the time, it's, quote, non-contact. They do it to themselves, and almost always those individuals have very, very nice flexibility, better known as hyperextensibility. And as you saw with her, or what you will see is that there's a very nice hyperextension. In fact, it's several degrees. And that is the norm for individuals who have torn an anterior cruciate. In fact, I kiddingly say if you ever in the clinic see somebody who had a non-contact ACL and they are tight, you can give me a call, collect. And I'm pretty comfortable that I'm not going to get too many phone calls. The very nice thing in this case is, though, it's a presentation of the process of today. And the process is that we basically schedule the surgery based on getting their motion back, having them being able to activate fully, and then looking at their schedule when it will fit. And in her case, they've actually delayed the surgery for a significant length of time until it will actually fit her schedule. And the one part about that is that she has to play along with this, and that is we don't want her going out and doing activities where she's now going to put her menisci at greater risk and also the articular cartilage. So basically, during the time where someone is working along like this, she basically she can ride a bike, which is a very good quad activity. She can do activities where everything is feed forward and she is controlled, but what we don't want her to do is go into activities where she has to react to others and place herself at risk of developing giving way episodes, because every time your knee gives way, you dramatically increase the opportunity that you would tear a meniscus. So basically, in her case, we're basically allowing her to go along, be controlled. She can do controlled activities, and then she's going to have her reconstruction. We're here with Rachel, and she had an unfortunate event a few months back. She decided that she didn't need her anterior cruciate in her right knee, so she provided us with a model who's going to allow us to do some things today that makes it a little bit more fun because we actually get to see some things. First thing I like to do whenever I'm assessing anyone is go into the standing posture and just have them stand. And what I like to do is look at orientation. And what you'll see with Rachel a little bit, go ahead, spread your feet just a little bit, is that she has a tendency of being a little more valgus than most of us. Most of us have a tendency to be a little more varus in orientation. And the other thing that I would want you to kind of note with her, just kind of try and make muscle here, tighten up. And as you note when she tightens up, go ahead, tighten up the other side. And what you're going to note is that as she does this, she has kind of this little grabbing, if you will. And what I really like to do with this is I like to use the terminology that I'm not going to have her turn sideways for you. Okay, and go ahead and relax back the way you like to relax. And you notice she does hyperextend some. And we'll demonstrate this a little bit better when we do some testing on a table here in a moment. But what I want you to kind of appreciate is people who tear their cruciate ligaments almost always do it on their own. They don't have to have help, they do it. She's a little bit different because she actually had some injury mechanism. It was a little awkward. But the point is, most people, when you tear an anterior cruciate, you tear it all by yourself. It's non-contact, if you will. And 80 to 90% of the time, that's the orientation when it occurs. And what we're going to do here in a little bit is you're going to notice that hyperextension, almost always people who tear their cruciates non-contact have hyperextension. It is almost automatic. You almost never will find someone who has tighter hamstrings tearing their cruciate. Kind of an interesting thing, if you were to look again at the overall orientation, that is with females, a little bit of valgus and that hyperextension are the two things that we almost always will find. So one of the things we are really worried about with all of these individuals, as they continue to have a gait pattern, they start to develop more and more recurvatum, if you will, and they're living on this lateral side of their joint. And we'll have Rachel just stand over there just a little bit. What we basically see with these folks as this occurs, as they ambulate, as they land on their heel, they have a tendency of collapsing back into their posterior lateral corner and attenuating it, stretching it. And if you kind of think about it from the side, you would see this occurring. That would be the action. And it evolves over time. And we don't see this as much anymore because most people, like Rachel, end up having their surgery done relatively soon after the injury. But if an individual goes for several years before they get their reconstruction, unfortunately, they will keep continuing to stretch back, stretch back, stretch back. Every step, when they land, they develop a thrust. And the original work done on this was done in Cincinnati by Dr. Frank Noyes, and they even talked about the idea of double varus, triple varus, and different orientations. What we in PT can do is appreciate that we want to make sure that whenever possible, we take them out of that position. So how do we do that? Well, very simply, I'm going to have Rachel go over and grab the little unit right over there on the table for me, better known as heel lift. Yep. And if I take a heel lift and put it in the shoe, when this person now is bearing weight, they will have a tendency, as you will note, of staying out of that thrust position. So they stay in a little bit of flexion, which prevents them from thrusting back. It's really hard to thrust back when you're in a little bit of flexion, when your heel is elevated slightly. So it's one of the techniques that you can use to very effectively help try to minimize that development, particularly in someone who may be living with a cruciate deficiency before they have their reconstruction. After someone has their reconstruction, when we start our progression with weight bearing, putting a lift is a very good idea, and we may recommend putting the lift under both sides. Make sure you stay balanced. One of the real interesting things you will see with individuals who have had surgery or have had injury to a significant ligament, one of the primaries in particular, and even though she has not had surgery yet, she exhibits one of these nice little things that you can always use. If you have the person activate the uninvolved extremity and make it as tight as possible, and you can palpate, she has a wonderful VM. Okay, relax. Now activate that side and come in and you will palpate, and you can see that, and you can go ahead and tell them, what did you say?
It's a lot softer.
It's softer and squishy is the term she used. And that will be that way even after surgery, after rehab. It almost always is a significant palpable difference. The other thing that's very interesting is that if I have her pull her, and she's got tremendous hip flexor, and that side, not so much. And again, she's not had surgery, but she had the injury, and this demonstrates the impact on the total extremity. And a lot of times people forget how significant that really is. And people, when they work on their rehab, a lot of times you'll end up having somebody, you think, gosh, we've done everything, it's as good as, it's perfect, and then you do these and you'll realize, they're still not. Don't get upset about that. Realize that's a part of this. And we may be able to ameliorate this some, but she may always remain not quite the same tonal qualities in that VM. Now, a lot of people have misinterpreted this. Again, if you go back to the original work in 1968 of Acl and Perry, when they published this and they talked about the VM being important, et cetera, people misinterpreted that to basically be that, well, we need to isolate and train, and in fact, in their work, they talked about in extension that you have a very strong VM activation. Well, the other thing is the VL is very active in extension as well. It has to be because the patella lateralizes as it goes into extension. There's no way to isolate the VM. we turn on the quads. And so the way I like to express this to the patient, I will say to Rachel, just realize that your vastus is kind of the mirror of the musculature of your extremity. And your muscles are not perfect at this point because they're inhibited, they're shut down some. And that is going to be reflected by that muscle being able to tell you that very nicely. So it's the mirror, particularly you can use the mirror of the quadriceps, or you can say the mirror of the lower extremity. The classic testing for the anterior cruciate and the posterior cruciate always began with the classic assessment of the anterior drawer and the posterior drawer. Over the last 20 years, a lot of individuals have said that, well, I don't even use the anterior drawer. Well, you have to do the posterior drawer test, and since you're in the position, and the technique that I like to espouse is using the additional loading going posteriorly before you come anteriorly and vice versa. It's automatic and it's in the position that you're in. Approximately 80 to 90 degrees of flexion. We want the individual to have their hamstrings relaxed. And this is really important because I want you to just watch what happens when Rachel raises her head. Did you see the increased tension in the posterior thigh and relax? There's actually an increase in tension. And we don't want that because if she has activation in her hamstring, she can negate the test. So again, she's relaxed. And the second part of the test is that as you apply your loading, people are taught to put their thumbs at the joint line. And it's a nice technique, but the important thing is that when you apply the load rapidly. So it should be a rapid loading. And what I like to do first is I push her posteriorly before I pull her anteriorly. Now she doesn't have a huge displacement. She's actually fairly close. In other words, she's tight, if you will, in that regard. Doing the posterior drawer, we pull her anteriorly, as you can see, we're stressing, and then we thunk her back. Thunk, 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 and she can feel it very nicely. Now, that is the classic anterior drawer, posterior drawer. Now, for doing the anterior cruciate, again, about 25 years ago, the International Knee Documentation Group was formed, and what they were basically trying to do was standardize the way they do assessment throughout the world. And one of the challenges with that is that there are some tests that require multiple structures to be damaged. And in this case, this was one of the real challenges. For the anterior drawer, it's hard to make sure that you don't have something else interfering. And so the Lockman test became popularized. And the Lockman test, for those of you that have not done a lot of these, is doing basically the anterior drawer test at approximately 20 to 30 degrees. So we take the knee to 20 to 30 degrees. She remains relaxed. Your upper hand must be outer, and it controls the femur. And the lower hand does the loading, pulling her thunk, 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 okay? Now, as you do this, a couple of basic things to appreciate. For some of you, again, with smaller hands, you'll find that the tibia wants to rotate, or the femur wants to rotate, and you really have to work at controlling that. The second part of it is that with smaller hands, again, you may find that it's a challenge with a very large limb. We're going to show you some modifications of the drawer or the Lockman that you can use, but do appreciate that it is challenging sometimes because no matter what you do, something wants to rotate rather than allowing you to keep it be pure and allowing you to get a test for a structure, and that is what the international knee documentation process was all about. The Lockman was the best test to give us a direct assessment of the anterior cruciate's integrity. Now, the most important part of the integrity is the endpoint again. So just as with the medial and lateral, the same thing is going to be true here. We get her to relax, and as we apply our loading, we accentuate the endpoint by starting and then allowing us to have greater displacement. And as we do that test, there are a couple of things to keep in mind. When you go to the opposite extremity, the upper hand must be the outer hand, and the lower hand must be in the same position on the tibia to allow us not to have you pulling into internal rotation on one side and external rotation on the other side. It makes it more challenging, And you have to really work very, very hard to make sure that you don't allow your hands to not get altered in position. So when we go to the opposite limb, the lower hand is on the tibia, the upper hand takes the femur. And as you look through here, you can see we get increased displacement, but we don't have a thunk on the end. She's thunkless. And she's kind of smiling because basically as we do the test, you come to your end point and there's no end point. Now, I'm just going to demonstrate if we do the anterior drawer in this position with her, the same thing is true. You can see displacement and there's no end point. As anterior cruciate injuries became more and more prominent and more interesting, if you will, physicians started to look at ways of documenting this more efficiently. And a part of this was the creation of the International Knee Documentation Committee, and they then created an International Knee Documentation Form. And as a part of that, there were a couple of things in it that we in physical therapy got to help with then. And one of the fun things was trying to document how well we really assessed the knee. And one of the things that was really very, very impressive was physicians were very, very attuned to telling us what the problem was, but if we asked them how much things were moving, they were horrible. And as a part of this, a group in San Diego created the KT devices. And for those who not, KT stands for knee tester. So it's, really, really classy, used a lot of scientific marketing concepts. So the knee tester was actually formed, and I actually have in my hands what we call the baby KT. This was never marketed. And what basically I'm going to be able to do is demonstrate for you the way the concept of knee arthrometry and its value and what it was allowing us to do. And one of the first things was somebody like this, what you noticed with Rachel just a little bit ago is that as we checked her, she has really good firm endpoints, but obviously on the involved extremity, she has significantly more displacement. So what was done was to create the ability, and what you'll see on this dial is that as this moves, we're getting a dial giving us a displacement in millimeters. And there's a little thing on here that says joint line. So we find her joint line, we stabilize the device, and this, if you remember, is her normal limb. She has about 2 to 3 millimeters of posterior drawer, which is the norm for this position. And then she has about 8 millimeters of displacement. And we then go to the involved side, get it about the same position. And she has 2 millimeters of posterior. And she has 13 to 14 millimeters of displacement. Now, the original description of this was that if in fact you have more than 3 millimeters difference right to left, you have a complete disruption of the primary ligament, in this case the anterior cruciate. Now, notice I did the posterior to start, and both of them had about 2 to 3 millimeters on each side. So when I then did this for the testing, she clearly has 5 to 6 millimeters more displacement on the involved than the uninvolved. Now, what this allows us to kind of go into the surgery, if you will, knowing is that, she has the complete disruption. Now, if you do an MRI, it basically gives you similar information that would say that it was completely disrupted, but it wouldn't give you just how much slop is in the system. So this kind of gives us a picture of how much overall motion she has, what her other restraints look like. Now, what's kind of interesting about this is that passive assessment of a single primary structure of this nature is of limited functional value to us. And what I mean by that is, this was published in 2004. Coker actually took a group of individuals who had had ACL reconstructions, and they looked at their KT measurements, and they did a whole bunch of functional tests, and then they also did the rotary instability test. And the rotary instability test in this case were to look at what's the rest of the capsule look like. And when they looked at the rest of the capsule, they found a horrible thing, that if she has more displacement passively, comparing the surgical side to the non-surgical side, if she has 2, 3, 4 millimeters more on her surgical side, she may be functioning incredibly well. However, if she has capsular problems and has her capsular restraints are stretched, that correlated very, very well with individuals who were not necessarily performing well. So what we kind of learned real quickly from that work was that if we have individuals who have a little bit of extra slop, they may be functioning just fine. But if they have that extra slop and they also have capsular damage, they don't function fine. They may be the ones that are having significant problems. And so what we kind of learned was that's been kind of the impetus to start to really look more and more towards doing surgical types of things to possibly address secondary restraints that may have been stretched or attenuated, if you will, or also the idea that at surgery we may want to do a better job of trying to create anatomy, and that's the concept of doing double bundle reconstructions rather than just putting in a single graft, doing double bundle grafts. Now, the group in the United States that's leading the charge on this, if you will, has been the Pittsburgh group, and Dr. Fu and Jay Irgang is the therapist that's worked with them the most. And what they basically have shown is our clinical results are equal, but they haven't been able to show that they are superior. What they're hoping is that over time, that by having a double bundle and having addressed the capsule, they will actually be better results downstream. But at the moment, they're always as good as, not better than. So that's at least the good news if you think of it in that fashion. Now, as we documented, the best test for the anterior cruciate, of course, is doing the Lachman test. Now, what's kind of interesting about that is that it was actually named by for Dr. Lachman. An individual published it and said that, he had learned it from Dr. Lachman, and when they then talked to Dr. Lachman, they said, well, we ought to call it the Ritchie test because that's who I actually learned it from. That being as it is, what we're now going to do is we're going to start talking about rotary instability and the effects of the capsule. And if we kind of think about it, as I pull and do an anterior drawer, is I pull her anteriorly. What's really restricting that motion is obviously the anterior cruciate, but also both the medial and lateral capsules, as particularly the posterior aspects of those, and to some degree the anterior capsule. But the idea is the capsule. Now, a kind of a cool way to think about this is to kind of think about like a sleeve on a coat. If I pull forward on a sleeve, things get tighter in the front, things get tighter in the back, okay? What I'm now going to add is what if I rotate a little bit? So what we're going to do is we're now going to start rotating the tibia a little bit. And when that happens, this becomes lax, this becomes tight. Well, that's exactly what we're going to do to the lower extremity. We're now going to start pulling the tibia in internal rotation or a little external rotation. And this is actually originally described as rotary instability, and it was really described in 1968 by Drs. Slocum and Larson out here on the West Coast. And what we'd like to now demonstrate is that what we do is we put her in neutral, and we sit on her foot, and we do our drawer test. And as you can see, nice end point, thunk, thunk, everything's cool, okay? This is her normal side, remember. But you see a nice displacement. Now, if I turn her foot into maximal internal rotation of the tibia, it negates the test. It's gone. Well, that's not doing the test the right way. Doing the test the right way is that we internally rotate just a few degrees so that we just tilt the scale, if you will, just a little bit. We internally rotate her a little bit, which then should tighten her posterior lateral side. And then we apply the test, and she tightens up. She's normal, okay? Then if we externally rotate, again, if I do it all the way, she's tighter in a tick, okay? If we externally rotate her just a little bit and repeat it, now there's a little motion. So that's the beautiful thing about doing the drawer test. Now, to practice this and really get good at it, you can even do the test in neutral and close your eyes. And as you apply the load, you will start to feel that you may be biasing. You may actually be getting more motion either from the lateral side or from the medial side. Now, what we're going to do is we're going to go over, you notice that she tightened up both ways. We're now going to do this on her involved extremity. Now, if anything, in neutral, of course, remember, she's got the displacement, relax, there we go. If we externally rotate just a few degrees, that's going to tighten her medial side. And pretty much, doesn't do much. Now we're going to internally rotate a few degrees. And she does tighten up, okay? So her capsule is good, which is really good for her, because if her capsule had attenuated or been injured with that initial injury, then she would be at much greater risk of having secondary problems, including the meniscus and other things as well. But that's the good news, okay? So her capsule is intact. Now, the next test that we like to do in the sequence for rotary instability is to start doing the tests that require multiple structures to be damaged. Now, she's not going to demonstrate a whole lot of that because she's intact. So I'm going to demonstrate on this side first. And the first test I'm going to demonstrate, this was popularized by the Canadians, and it was Dr. Galway and McIntosh. So our Canadian friends, Galway and McIntosh, taught us this one, and they basically called this the pivot shift test. And what they demonstrated was that if we take the tibia into extension, and we hold the tibia in our hands, and we let the femur just be on its own, gravity will actually pull the femur downward and backward, if you will, like this, if we're holding this, if they have a torn anterior cruciate. And then what Galway and McIntosh then recommended was to apply a valgus load. So some people would do it in this fashion. They would come in like this, and they put a little valgus, and then they flex the knee. Okay? So we hold the tibia, we put a little valgus, and we flex the knee. And you notice nothing is happening. In the individual who has torn their anterior cruciate and has stretched out the posterior lateral corner, this is what would happen. When I hold her tibia in my hands, her femur would do this. When we put valgus, that loads and basically catches and puts the femur posteriorly. As we then flex the knee, when we get it approximately 30 degrees, a wonderful thing happens. Between my fingers is my IT band. And you'll notice at about 30 degrees, my IT band goes from being posterior, it now becomes anterior to the axis of rotation. That is what pulls the tibia and the femur into alignment. And when that happens, there's a snap reduction that occurs, and that's called the pivot shift test. So I'm going to just really gently show you on this side. She's going to relax, soft thoughts and puppy dogs. And all I'm doing now is I'm holding her tibia in my hands. And I'm giving a little flexion, and she could feel a little bit of a shift. You could feel it kind of reducing. But it's not graphic. It's not something that you're going to see. But if you watch very carefully, I'm going to pull you over here a little bit. Watch my finger right here. When I give the valgus, you can see there's a little disruption of the, and that is her reduction that's occurring right there. Now, it's not very graphic, but it is occurring. Now, that's because her posterior capsule is not stretched out. So she's not sagging back. All that's happening is the tibia is anteriorly displacing slightly. And so what we're seeing is that when I hold her tibia in my hands, I can have just a little, there's just a little reduction. Just, you can feel it's real subtle, it's just a little that occurs. Now, some people try to grade that. And then when they try and grade it, they call it, is it gliding, is it shifting, et cetera. And it's really hard to grade it very, very well. To try and modify the test, and the reason was this. If I forcefully pushed her into valgus when I did this, and forcefully compressed as we go through the range, it is uncomfortable for the patient. And so the pivot shift test was frequently modified. And the person who published this was Dr. Frank Noyes out of Cincinnati. And what Dr. Frank Noyes called this is the flexion rotation drawer test. And what he does is exactly the same position. We go into extension, we hold the tibia, but instead of valgus loading, and you can see, when I go like this, you can feel it rocking. That's the valgus. Instead of going into valgus, all one does is compresses and then flexes. And his concept is that as we compress, we kind of trap the femur down and back a little bit, and then as we flex, it will still reduce, but it won't be pain-producing like it is when we have done the valgus loading. And that's called the flexion rotation drawer test. And you will see that people will use that, that's one modification. But what we're now assessing is the integrity of the posterior capsule laterally primarily for this. Now, as we look at rotary instability, people at one time pretty much got away from this during the 90s, and basically it was because we became very adept at taking care of the anterior cruciate and thinking, if we just did a good job with the anterior cruciate, it'll take care of the joint, it'll make it quiescent, it'll make it quiet. And what we found was, it's probably not true. And as I said, 2004, Coker showed us that rotation is probably really important to function. And now, of course, people are really working very hard at attempting to do anatomic reconstructions to better recreate the anatomy.